Asthma by Portia Toon Battle. This is Braylon. She's 5 years old and full of life. Judging by these pictures, she's what most would call a normal, healthy child, right? Wrong. In 2014, Braylon nearly lost her life after a severe asthma attack. She was in and out of hospitals for months. She now lives a very active lifestyle thanks to her healthcare providers and her strict asthma medication regimen. In this presentation, I will discuss the pathophysiology and disease process of asthma, various options for management, pharmacologic side effects and contraindications, and the education that all patients need to understand. So, what is asthma? According to the American Lung Association, asthma is a lung disease that makes it harder to move air in and out of your lungs. Asthma is a chronic condition, meaning that people live with it every day. Although there is no cure, asthma can be managed by lifestyle and medication. Asthma can be life-threatening, but with the right treatment, many live normal lives. Morris states that the pathophysiology of asthma is very complex. It involves airway inflammation, intermittent airflow obstruction, and bronchial hyperresponsiveness. There are several phenotypes of asthma with two main classifications, atopic asthma and non-atopic asthma. According to Lynn and Cousteau-Reese, atopic asthma begins in childhood and is linked to different triggers that initiate wheezing. Allergens such as dust, smoke, food, drugs, and pollen act as triggers, which causes the excessive release of IgE. This activates B lymphocytes. When IgE binds to the cells related to inflammation, inflammatory mediators are released. This causes airway inflammation and bronchoconstriction. Lynn and Cousteau-Reese also states that non-atopic asthma usually occurs in adulthood and is sometimes secondary to viral infections. There is no IgE response involved, and there are significantly fewer triggers. According to the Global Initiative of Asthma, asthma is defined by the history of respiratory symptoms. These symptoms include wheezing, shortness of breath, tightness of the chest, and cough, and they vary over time and intensity. When making a definitive diagnosis of asthma, the history of the symptoms previously mentioned are only part one. With part two, there must be a confirmed variable expiratory airflow limitation. Tests used to confirm this variable expiratory airflow limitation include spirometry, bronchial challenge test, pulmonary function test, peak expiratory flow, FEV1 FVC ratio, and pulse oximetry. Global Initiative for Asthma reports that the physical assessment of an asthma patient is usually normal. Wheezing is the most frequent abnormality, but may not be present at the time of assessment. Even when assessing a patient during acute exacerbations, the patient may be experiencing what is called silent chest, and there will be no abnormal breath sounds. Other physical signs of respiratory distress or respiratory failure may be present, such as dyspnea, tachypnea, cyanosis, fatigue, confusion, and anxiety. The clinical presentation of asthma may be wheezing, chest discomfort, shortness of breath, cough that worsens, especially in the morning and at night, and the inability to perform activities of daily living. The treatment of asthma is guided by the severity of the disease. Many providers use a stepwise approach to treatment utilizing lifestyle modifications and pharmacologic methods. The Asthma Allergy Foundation of America states that asthma is considered intermittent when the patient experiences symptoms less than 2 times a week and wakes up less than 2 nights a month. Mild persistent asthma is when the symptoms are present 2 or more days a week and the patients are awakened 3 to 4 times a month. In moderate persistent asthma, the symptoms are present every day and the patient is awakened by them at least 1 night a week. Severe persistent asthma is when the symptoms are present every day and the patient is awakened every night. Non-pharmacologic treatments of asthma includes the management of comorbidities such as obesity and anxiety, environmental control, avoidance of allergens, smoking cessation, avoiding tobacco smoke, spirometry, and breathing exercises. Teach back and demonstration are critical when discussing these treatments with your patients. Up-to-date states that all patients should work with their provider to develop an asthma action plan that should be followed when their peak flow decreases. In the green zone, the lungs are functioning normally. The patient should continue on with their daily activities and treatments. In the yellow zone, the airways are somewhat narrow, and the patient should implement short-term changes or increases as discussed with the provider. The red zone signifies severe narrowing of the airways and requires immediate treatment. The patient should utilize the quick-acting reliever inhaler and any oral steroid tablets discussed with the provider. An emergency care plan should be developed in the event symptoms worsen or do not improve after treatment. Treatment in step 1 of asthma therapy is for those with mild to intermittent asthma. The medication of choice is a short-acting beta antagonist. Examples of short-acting beta antagonists or SABAs are albuterol and terbutaline. SABA's method of action is bronchodilation. Step 2 is considered to be regular preventative therapy. This patient will still have their rescue inhaler, the SABA, but a low-dose inhaled corticosteroid, or ICS, will be added. The mechanism of action of the ICS is an anti-inflammatory action and reduction of airway hyperresponsiveness. Examples of inhaled corticosteroids are listed on this slide. At this point, therapy with a low-dose ICS and SABA has not been effective, so the provider should begin add-on therapy using 1 or 2 controllers and keeping the as-needed reliever medication. For step 3, the recommendation is a combination low-dose ICS and LABA, long-acting beta antagonist, as maintenance treatment with the SABA as needed. Another option is a combination of low-dose ICS and formoterol as both the maintenance and the symptom relief treatment. The mechanism of action of the ICS-LABA combination enhances mucociliary clearance and dilates the bronchioles. There are many ICS-LABA combinations available for use. A few of them are listed here. In step 4, those doses that were used in step 3 are not working. So they need to be increased to a mid to high dose because the persistent poor control. If the increase in dose is not effective, Providers may add a leukotriene receptor antagonist or slow-release theophylline. The leukotriene receptor antagonist and theophylline both have anti-inflammatory and bronchodilation effects. Leukotriene receptor antagonists also reduce hyperresponsiveness, secretion of mucus, and oedema. Finally, step 5. At this point, oral steroids need to be introduced. The goal of treatment is to use the lowest dose of oral steroids to adequately control the symptoms. Providers will often try a variety of other treatments at this point to minimize long-term steroid use because this could become problematic. The patient may be referred to a specialist that is better equipped to treat them. Meg Dafour and Lugogo states that providers should remember to provide a written action plan and encourage self-monitoring to aid in the self-management of this disease. Modifiable comorbidities and risk factors should also be discussed, and treatment options should be given to the patient. For example, smoking cessation, therapy for anxiety, weight loss for obesity. These are all non-pharmacological therapies that will be beneficial to the patient, not only to help with the asthma, but to better them as a whole. If symptoms are still uncontrolled, the provider should step up therapy. The provider should consider stepping down therapy if the patient's symptoms have been controlled for 3 months with a low exacerbation risk. There's a lot of patient education involved when living with asthma. The providers should provide resources such as handouts, support group information, and useful websites. Some things that should be highlighted are to avoid known triggers, take medications as prescribed, make your home smoke-free, manage anxiety, improve indoor air quality, and avoid outdoor pollutants when possible. Manage weight, keep humidity levels low, and keep immunizations current, especially flu and pneumonia. It is imperative for the providers to stress the importance of strictly following the medication regimen. Periodically, the provider will assess the patient's adherence and make adjustments as needed. SABAs. The patient should be provided written instructions when using any medication, but important points to stress include taking the medication exactly as prescribed for the quick relief of asthma symptoms. The patient should always carry this medication anywhere that they go. The side effects include increased heart rate, shakiness, and anxious feelings. These side effects should be discussed, and the patient should report these to the provider if severe. Inhaled corticosteroids. Patients should take this medication exactly as prescribed. To decrease the likelihood of developing thrush, the patient should rinse their mouth or brush their teeth and tongue after each dose. Some people will develop a hoarse voice, sore throat, cataracts, glaucoma, easy bruising, and osteoporosis. The provider should really take the time to discuss the signs of these conditions and instruct the patient to contact the provider immediately if they appear. Inhaled corticosteroids and long-acting beta antagonist combination. Patients need to understand this medication does not take the place of their short-acting beta antagonist rescue inhaler. They should rinse and brush to prevent thrush. Side effects include nasopharyngitis, headache, upper respiratory infection, pharyngeal pain, sinusitis, pharyngitis, rhinitis, influenza, back pain, nasal congestion, stomach discomfort, vomiting, and thrush. These medications must be used with extreme caution in patients taking beta blockers. Leukotriene modifiers are associated with very few side effects. Rare side effects include depression and mood alteration. If the patient is experiencing depression or having thoughts of harming themselves or others, this should be reported to the healthcare provider immediately. Side effects of theophylline include nausea, vomiting, diarrhea, stomach ache, headache, rapid or irregular heartbeat, muscle cramps, jitters or nervousness, and hyperactivity. This patient should be instructed to take the medications as prescribed. There's a lot of patient education on oral steroids as well. These drugs can lead to long-term issues if taken for too long. The provider should tell the patient to take only as prescribed and to never abruptly discontinue oral steroid therapy. There will be continuous monitoring while on steroids, and the provider will implement alternative therapies as applicable. Common side effects of oral steroids include increased hunger, insomnia, agitation, increased energy, and mood alteration. The patient should report adverse effects to the healthcare provider. Health Research and Educational Trust reports that when a provider is culturally competent, they are able to provide care to patients with diverse values, beliefs, and behaviors, including tailoring healthcare delivery to meet patients' social, cultural, and linguistic needs. Cultural competence is critical. This not only leads to better patient outcomes, it also reduces disparities. Braveman and Gottlieb states that despite challenges, controversies, and unanswered questions, the tremendous advances in knowledge that have occurred in the past 25 years leave little room for doubt that social factors are powerful determinants of health. When assessing a patient's psychosocial and socioeconomic status, it's important to ask questions like, can they afford this medication? Do they understand the education that I'm providing? Can they read the pamphlets that I'm giving them to take home? Do they have transportation to pick their medication up? Do they have transportation to make it to follow-up appointment? In considering these factors, as a provider, you're providing the best care that fits your patient needs based on their psychosocial and socioeconomic status. These are my references. Thank you for your time.